So it gives me great pleasure to introduce our speaker today, who is Professor Mark Morgan. Mark is a GP, educator and researcher with experience in rural and urban Australia. He's a professor at Bond University and co-lead of the Doctor of Medicine program, and his research focuses on patient safety, primary care data, shared decision-making and managing patients with multiple long-term conditions. He chairs the RACGP Expert Committee for Quality Care and represents the College on National Health Policy Committees. And he also holds a PhD from Flinders University and is a fellow of the RACGP. So welcome today to the presentation around social prescribing, and I'll pass over to Mark now.
Thank you, Tash, and thank you for inviting me to speak on something that I'm passionate about and really excited to be here and to have the opportunity to share. I would like to start by acknowledging the traditional owners and custodians of the different lands that we're on. I'm on Goomberry land here in the Gold Coast. I'd like to pay respect to elders past, present and emerging. So what is social prescribing? It's a buzz term. Some people hate the term because it's prescriptive. Other people find it helpful, but I think it's a term we're now stuck with. And there are several definitions of social prescribing. So one of the definitions, one of the simplest ones, is from the World Health Organization. Social prescribing is a means for healthcare workers to connect people to a range of non-clinical services in the community to improve health and well-being. The second definition, which is from National Health Service of England, goes a little bit further and talks about what social prescribing might address. So connecting people to activities, groups and services in their community to meet the practical, social and emotional needs that affect their health and well-being. And I think the third definition is actually the one that I kind of really like, which comes from Aspire, the Australian Social Prescribing Institute for Research and Education. That one reads, a trusted referrer connecting a person to a link worker who acts as a resource while the individual creates their own personalised plan, identifying opportunities and avenues for enrichment to enhance their quality of life. So that starts to talk about the possible mechanism of how social prescribing might work. So I gave some thought about how social prescribing might help healthy aging. And this word cloud describes some of the ways that social prescribing might provide benefit. So it can certainly help build skills. There's an example later of that I'll talk about. An opportunity to volunteer, an opportunity to discover or rediscover interests that somebody had in the past, or to build meaning into life. It can work through a goal-setting purpose. It can focus on isolation and loneliness by building confidence. Potentially, it's a mechanism for increased physical activity. It can certainly work and focus on improving mental health, either as step-down opportunity after a different mental health intervention or alongside other mental health interventions. So lots of different potential ways that social prescribing could help an individual. What I'd really like feedback from you is what sorts of activities and groups that you're aware of that might that are not health related, but we might connect a person to. So I'd really like to hear about anything that you've either connected a person to through doing a bit of social prescribing, or whether or not something that you're aware of in your local community that might fulfill some of these roles. I know in the early days of thinking about social prescribing, the RACGP the Royal Australian College of General Practitioners made a connection with parkrun, seeing that as a way for people that were fit enough to run or walk 5 kilometres to join a community group. So love to hear from anyone that would like to just unmute and suggest activities that they've heard of or are aware of that might fit the bill for social prescribing. I might just start with Tash. In the chat, Christine has just suggested a book club, and yeah, brilliant idea, because it doesn't take a lot to set up a book club. No huge resources, expenses, or risks to manage. So that's a great opportunity. So Kristen suggested libraries. In fact, libraries run a whole bunch of different activities, and I heard through social prescribing meeting that there were more libraries than Macca's in Australia, which is an amazing statistic. Starting to see many ideas come through. Men's Shed, patient support groups, so particular condition-related support groups. Community centres as a centre for social prescribing. University for Third Age. You can see where that fits with skills building. When I went through the thought process around social prescribing for the first time, what I realised is that I knew about a bunch of local opportunities, and the person working in the room next door to me knew of a bunch of opportunities, but our collected knowledge didn't overlap very much, and so there needed to be some system to bring this together, and that was missing. I noticed Christiana's talked about volunteering at a community centre where they do meals, knitting clubs, dances. So that opportunity to volunteer really does add meaning back into life, but it actually also helps the local community. So it's building strength in the community, resilience in the community, not just for the individual. One organisation that's very good at collecting available resources and presenting them as a sort of list are the local councils. And many of the councils, particularly in Queensland, have gone a long way down the track of providing a sort of clearinghouse of ways to get involved. Excellent. Thank you. Let's keep moving. So the next thing I'd like to think about are what are the features of group activities that might be suitable for connecting with the health service. So clearly they need to be accessible to people, both local, from a transport point of view and from a cost point of view. They need to be safe places. We can't be connecting to people to places where they're going to suffer injury. They need to be interesting and sustainable. People are not going to do something just because they're told to do it unless they actually it aligns with their own goals and their own needs and interests. And ideally, we want to get some health benefits from social prescribing. So if it's loneliness, then it's connection to people. If it's a need for physical activity, then it's doing something that involves moving. So you might have thoughts about additional features that make a good social prescribing. I noticed in the chat people suggest age concerns, St. John's, befriending services, all very valuable, and then arts and crafts, morning teas, informal referrals to other supports. We know that one of the things that can upset high quality aging in home is when somebody is socially vulnerable and they don't have supports near to them, and it just takes one the resilience there to bounce back after the last remaining support is removed from somebody. So having a network and having more options for support is really important. So for the health system, there's a couple of quotes here about how social prescribing could be important. The first quote is from the then CEO of Mental Health Australia. A prescription to improve one's health should be much more than a piece of paper you take to the pharmacist. And the next quote was from the Honourable Jed Kearney, who was the Assistant Minister for Health last year. Social prescribing is such an exciting frontier in the health sector. Social prescribing charts a new way forward for healthcare that better connects patients with community services and programs, empowers and supports patients to better manage their health and well-being. I think that really describes the whole picture. So when I present and talk about social prescribing, most people go, yes, I can see that. It's kind of almost common sense and obvious, but there is a gap between what's common sense, obvious, and should happen, and what does happen, and that's what I'd like to focus on as we move forward through this. So the health service represented in the centre of this image, allied health, general practice, pharmacy as a sort of a community, and hospitals, health system funders, all working on ever increasing complexity, ever increasing challenges around workforce, around the spread and distribution of workforce across the country, around the blowout in hospital budgets and the knock-on effects to community providers, and the disconnect between the different parts of our health system. And really the health system is a small part of what's out there, because out there, as we've discovered, there are community groups, opportunities for arts and craft, there's a whole nature and wildlife, there's opportunities for physical activity that go way beyond that boutique one-to-one referral that's the kind of MO of the health system for delivering healthcare. It's not scalable to expect everyone that could benefit from physical activity to be referred for one-on-one or even small group visits to an exercise provider such as an exercise physiologist. It just doesn't make logical sense. The difference between the size of service provision and the size of the need is too huge. And when I'm in the policy space, I often hear trade groups arguing for the importance of their trade, but not really acknowledging that they don't have the capacity to deliver on the promise. And it happens when GPs are talking about our role in the health sector, where we often put ourselves up as able to do everything, and it happens when I hear other trade groups talking in policy spaces about their the part in the jigsaw that they play. But if you actually stand back from it, the capacity isn't there. It has to be based on stratifying need. So I'd like to start with a bit of a story of social prescribing, because I think that will fill the policy context. My story actually starts way back in 2007 in a research project that ran in multiple centres, most of them rural, looking at the management of depression in people who also had either heart disease or diabetes or both. And that True Blue series looked at a more holistic management of the physical conditions alongside the mental health conditions. And one of the key components was empowering our practice nurses in general practice to understand what the local opportunities were for physical activity and alleviation of loneliness and learning more skills. We didn't call it social prescribing at the time, we called it behavioural activation. And our nurses became the case managers for these people to make sure that things were happening that were necessary for healthcare, but at the same time to really address people's individual goals and to use community resources more effectively. And that was a successful project. The intervention group did far better from a mental health perspective. Their depression scores as a group improved much more than the group that had usual care. And the qualitative analysis demonstrated that it was a model that was very acceptable to all the clinicians and acceptable to the recipients of the care. Back in 2019, I heard that the National Health Service in England was starting to throw significant investment into people they called link workers. They're also called community connectors or wellbeing consultants. And these link workers were trained and embedded in general practice so that GPs could refer people to a link worker for a needs assessment, and the link worker could connect the person to a bunch of community activities, services, with a view to addressing the social determinants of health and well-being and improved physical health and improved mental health. And so, that was very exciting when I heard that the UK had thrown serious taxpayer money into developing this system. And I thought, well, look, how can we bring that to Australia? And so in 2019, end of 2019, I partnered with Leanne Wells, the CEO of the Consumer Health Forum of Australia, and Yvonne, to bring together a social prescribing roundtable hosted by the Royal Australian College of GPs to see what was already happening across Australia and what the next steps would be to building a social prescribing system that was accessible in Australia. And I had an ulterior motive as well, because I don't know whether any of you have spoken to UK GPs, but they're a miserable bunch. They really are. The morale of that workforce is rock bottom and has been going downwards. But when you speak to them about social prescribing, their eyes light up and they start to get excited about how, for once, they can actually do something that feels positive and useful and kind of patient-centered and not just battering their head against an underfunded system. So I had the ulterior motive, really, of thinking about whether or not Australian GPs would find social prescribing something that gave them an enthusiasm for practice again. So that was it's not the main purpose, but it was there in the background. So our round table, you can see in the top picture on the right-hand side, if you've got good eyesight, that Genevieve Dingle, Tracy Johnson, Jane Nelson, other people involved in this. And I keep seeing the same people coming up when we're talking about social prescribing now. So it's quite exciting that the same people that bought into this right at the beginning are still highly involved. So, great initial step. Some of us from that meeting were invited to contribute to the Health Minister's National Preventive Health Strategy, and Not surprising, the National Preventive Health Strategy has a statement about social prescribing, talking about enhanced referral pathways to community services to improve health and well-being need to be embedded in the health system at a local level with a focus on self-care support. So there's, a clear sort of weight of agreement about this. That was 2019 when these discussions were happening. A few of you might remember this. COVID made the need for social prescribing so much more important. Lockdowns and other rules around prevention of spread of COVID effectively supercharged loneliness and isolation.
That's what I was thinking. But he's not a very strong stomach.
And COVID also was simultaneous with the kind of growth of Netflix and other things like that to bring your entertainment into your home. Food supply, things like Uber Eats, shopping done online. Amazon was building up at the same time to become mainstream. And so all the reasons why you might leave your home to get out and about started to be removed one by one during this time. So we've really seen a bit of an epidemic of the experience of loneliness and the phenomenon of isolation, alongside all of those increasing chronic diseases and survivorship of cancers and heart disease, which have led to people having a long and potentially productive and interesting life beyond their first chronic disease that we're facing and wanting people to do well with. So what's happened since in this story? Well, you, I hope, will all be aware of the existence of the Australian Frailty Network, bringing together researchers and policy thought leadership about the management of frailty and the prevention of frailty. I mentioned earlier a group has emerged to lead the social prescribing push through collation of research and providing a forum for people to get together and to develop policy and try and push the agenda along. That's Aspire. The Australian Health Policy Collaboration, under the leadership of Rosemary Calder, has been commissioned and has completed a body of work looking at the international evidence for outcomes and cost effectiveness and healthcare effectiveness for social prescribing. And that's not the only, these are not the only examples. The Royal Australian College of GPs has a special interest group led by Dr. Kuljit Singh, who are bringing together the GPs with a special interest in the opportunities that social prescribing brings. I've been describing this all from a very much health perspective, but I was having a conversation earlier today with research group about how you could just as easily have come from a crime and crime prevention and crime mitigation perspective and thought of social prescribing to deal with that, or from a workforce support perspective, using social prescribing to support people's quality of life in different aspects of the workforce. So there are other lenses you could bring to this, but focusing on the health lens, because I think that's probably an easier place to start. So internationally, I mentioned that the UK has really jumped in with 2 feet to support social prescribing, and data from 2023 suggests that just in that year alone there were 1.3 million incidents of people being referred to link workers by their GPs, and the National Health in England has committed to providing a link worker in every general practice. I also wanted to draw attention to an example from Singapore, where their wellbeing coordinator organised smartphone lessons to increase digital literacy. I was in Singapore last week talking about medical student places and their establishment of chronic disease and acute care clinics outside of hospitals, and all of those services are accessed via smartphones. You can't really survive without using smartphones and QR codes in Singapore. So this sort of intervention resonated with me to make sure people were not left behind. So what's happening in Australia? Well, there are dozens of projects funded in Australia looking at social prescribing. They're funded through research organisations, through PHNs and primary health networks. They are funded through state-based project funding, often in coordination with PHNs. In smaller ways, they're funded through the neighbourhood houses or community centres. So there are lots of time-limited projects in Australia. There's quite a focus on social prescribing for mental health needs, because I think that's an easy one to sell at a government level. But there isn't yet a social prescribing system or opportunity to really reach the potential for social prescribing. Some outcome studies have been conducted. The one I've drawn attention to here was across 5 social prescribing projects in Queensland. The small arrows represent the kind of 8-week outcomes, and the 18-month outcomes are represented by the large arrows. All of these projects involved a link worker, and the outcome measures they chose to focus on were things like loneliness, distress, quality of life or perception of health, and a concept called social trust, trust in others. And it's a very positive story. Hasn't yet been converted into a cost benefit analysis, because that's quite difficult to do. How do you measure the cost benefit of improving the volunteer sector or strengthening communities? But it certainly aligns with a lot of policies across government. But I think one glaring need is to have a simple set of outcome measures that can also become a way of putting a dollar value on social prescribing, because I think that will make some differences and help us drive a social prescribing structure for Australia. What have we learned through all the research and examples of social prescribing? Well, I think my key learning is that the population falls into 3 groups. There's a group of people that really don't need the support of a link worker or any other kind of direct health intervention to access community groups and services. They benefit from signposting, from the sort of things that local councils currently produce that say what's available, and they're able to find their own way to these services. There's a group of people that have such high needs that they need a team of professionals. They need trained social workers working with health professionals, working with service providers, people who might have complex legal, housing, mental illness, physical health needs that would bury a link worker in and make them unable to function and unable to be sustainable in their roles. And then there's the the group in the middle who would benefit from a needs assessment, some facilitation to really fit what's available out there in the community with what their needs and wishes are. And I think that's where the expertise of link workers might come into play, and where we could really benefit from some effective way of funding link workers accessible to the health sector to connect people. We've had some thoughts on how that might happen and produce some policy, but little traction as yet. And that's where the great minds here today are going to focus on getting some of your opinions on how that might happen. But the other question is whether or not link workers could be given some discretionary funding to manage small barriers to accessing care. Maybe a transport barrier, might be the need for some carer support to free somebody to be able to access community, whatever's holding them back that's within budget. So some discretionary funding that can be applied by the link worker would be I think the gold standard model. But you could immediately see how health funders would be afraid of giving discretion over funding, have that discretion distributed to a whole bunch of people that they don't have direct control over. So I'm posing some questions now that I'd like to engage either through the chat, or better still, if you're prepared to unmute and speak. But I'd love to hear from the expertise and experience of people on the call today, how you might imagine link workers being funded, or what skills and training a link worker might need, or how the system needs to support community groups so that they don't buckle under changes introduced through social prescribing, and how best to embed social prescribing in healthcare, and how to build a social prescribing system for Australia, assuming that you're with me that it sounds like a good idea and a good plan. So those are the questions I'm posing. I'm hoping we'll get some engagement now, otherwise it's going to be a strange end to this webinar. So please do feel free to contribute either through the chat or through unmuting. Tash, do you want to kick off though?
Thank you so much, Mark. That was an amazing presentation. And everyone, I do encourage you to unmute yourselves if you do have a question or some contributions. My first one is around the sort of cost effectiveness or cost benefit. I have seen some published work, although I couldn't find it just now, talking about sort of for every $1 invested, you get $3 or $4 sort of back. Do you know much of that literature, and can you talk us through some of the nuances there?
Yep, they're quite woolly estimates, and difficult for Treasury to pocket advanced savings in healthcare, because where you save and release capacity in one bit of the health system, another bit immediately sucks it up. So there isn't actually easy to realize that net benefit. So where I think the innovation comes is two ways. One is to start putting a value on community benefit, on building stronger communities, on supporting people. And the other might be a comparison is what is the alternative? What would it actually cost to provide education or skills lifting to somebody, to provide regular ongoing physical activity opportunities, to provide some sort of mental health support, to provide regular in-home contact for somebody that is isolated or experiencing loneliness, and to kind of cost that out and go, well, look, that's enormous cost. The cost of supporting social prescribing pales into a very small amount compared to that other. So I think there's, I'm not a health economist, but I think there's two ways to tackle this. I'm not sure the sort of Price Waterhouse or kind of people that do lovely reports and come up with that dollar figure that I've seen, whether that holds as much weight when you actually put a budget call in for it to happen.
Yeah, definitely that makes sense. It's quite hard to quantify, and yeah, totally agree. We have a comment from Amelia. I'm happy to read it out unless, Amelia, you want to unmute to talk about your comment. Give it a moment.
I mean, it might not be an environment that allows unmuting, so
Yeah, that's
yeah,
okay.
it's pretty noisy here, sorry.
No, that's all good. So it's around things coming back to money. So with older adults being reluctant to pay to participate in a few things, and they might be lacking motivation or support to attend an activity. So how do we overcome these barriers?
I can certainly describe some ways that those barriers have been overcome in examples, and that's a brilliant question, really. So the UK training of link workers includes training in goal setting and brief motivation, kind of psychological techniques to build people's motivation. And then they've backed that by various models of direct incentivization to the participants. So not just making it free to participate, but actually incentivizing on top of that by giving a number of free sessions to a gym, for example. This I think was aimed at a younger age group, but was with chronic diseases, but still able to attend gyms. So that was a direct incentivization, which seemed to work, and it scaled. The more times you went and attended, the more incentives you got. So kind of it was using the same sort of thing that are used in the algorithms for various kind of games to build motivation. In Singapore, they issued pedometers, or cheap smart watches to people, and started incentivizing, or they're starting to incentivize a minimum step count, and give you points that can be cashed in for services if you have done your minimum step count. So a very direct kind of command and control. I'm not sure it would pass all of our sensitivities over fairness, but was a really interesting model of directly tackling what was perceived as a sedentary culture. I think there's comments coming in thick and fast. So
There is. Just trying to look for ones that are related to funding. We've got a few other topics. Selena's talked about the MRFF or Grant Connect, sort of different grant opportunities for funding. I think that's a model that has been used sometimes, but perhaps it limits the scale up and rollout. Do you have any comment on that?
Yeah, I mean, as an academic and working in the university, the application for MRFF grants to answer important questions and to see something rolled out in a unlimited project is my bread and butter. It takes a group of people 6 months typically to put together a grant application. They have a success rate of around 10%, and then they're quite tied to doing what you said you were going to do. I think it's great to answer unknown questions, but challenging to scale. And at the end of it, there's no guarantee that the wonderful findings, the successful findings translate into government policy. So while I think it's an important part of this, I don't think it goes far enough. Grant Connect's a great organisation for supporting the application of those grants. So they're certainly an enabler, as would Research Australia, the organisation I was speaking to earlier today.
Yeah, brilliant. So another question on funding has come through from Kristen. She says, given the cost and poor outcomes for people once they enter the acute care system, it would make sense for the Commonwealth to invest in preventative care and social prescribing. On the same note, it would be great for community members to take on these roles as a social change that could also begin to curb societal and systemic ageism. Imagine a person goes into their local cafe for a regular coffee or even their hairdresser and they notice some changes or in a conversation. These individuals might have access to a tool that they could start the process of social prescribing.
That's brilliant, because that's thinking like a pincer movement, a sort of top-down, bottom-up approach simultaneously, which I think is really wise and good thinking. I'm certainly speaking to one of the instigators of social prescribing from the UK, who said that in one area of London, they found that culture, the way to reach out to particularly young men, interestingly, was through the barbershops. That's where their culture was. And we then joked about whether the British pub was a suitable or unsuitable place to access people and talk about social prescribing. So I think reaching out to people where they are, where the needs are, is part of this. Recouping or looking at that phenomenal, was it $1,200 a day average cost to have somebody spend 24 hours in an acute hospital, might be an underestimate, and whether there's any opportunity to release funding. I would have said in 2019, no, there wasn't. My experience of hospital and health services or local LHDs was that they were worried about what happened in their own walls, and what happened outside was not a direct concern. And through COVID, and I guess through the brain-numbingly obvious thing that what happens in the community does impact people coming into hospital and how people leave hospital, there's seems to be much greater enthusiasm for states that are predominantly the funders of hospitals to look at what they can do to manage or to benefit communities to reduce hospital admissions. And I think really it's not just a numbers game, it's the type of hospital admission, because the sort of hospital admissions that have complex social needs and care needs are exactly the sort of hospital admission where the medical side of things can be fixed up in a few days, but the discharge arrangements and the support needs in the community are missing. And so those hospital stays end up being quite long, and has a knock-on effect all the way back through to ambulance ramping, which of course is a hot topic politically across the country. So look, I think that's a really good suggestion. Certainly, do we talk at a state level? Do we talk at a local hospital district level? Or do we try and leverage at a federal level, given that the federal money goes to all the states to provide probably around half of hospital costs? So the best point, or do we do all of them simultaneously, which I think is probably what needs to happen to get the message across. And maybe that's where the health economists can go. We think we can reduce acute hospital admissions by even a small percentage, and put a dollar figure on that straight away.
Yeah, thank you. Now, there's lots of questions coming through, but I do have a sort of comment and question around the funding model. Do you see any of the aged care changes, particularly in the community aged care space, that could incorporate social prescribing or leverage it a bit more for their goals around rehabilitation and reablement?
Yes, I think that there are small barriers that need to be chipped away at, and those barriers are around kind of indemnity, who's responsible for the person that stumbles and has a fall, and around which are fixable. Those barriers can be addressed, I think, easily enough, and around that tension between what a person wants to do and what's aligned with their goals and what the health system thinks is a safe way to behave and do. And really, I think the closer we get to residential aged care, that it's my observation, but shoot me down if you disagree, that we tend to focus on too much on safety and not enough on freedom and opportunity. And I think that dial needs to be shifted to really allow people to make informed choices and have opportunities, even if it's not wrapping them in cotton wool and being 100% safe. I think there's a balance, and I think we get the balance wrong the further towards aged care that we get. From an indemnity point of view, I think that's the role of local councils with registered community groups to go, we'll deal with the indemnity side of things. You deal with what you do, which is volunteers and covenants.
Yep. And that is one of our comments as well around how can this be facilitated in RACF consumers who are often forgotten about or have limited access. Have you seen social prescribing done in the residential aged care setting?
What I've seen instead of social prescribing are people employed to provide some sort of non-health activities within the setting of aged care.
Yep.
And there's a suite of things on offer in the better residential aged care homes, but still, I think a lack of choice, and therefore the level of engagement of each individual. You know, I've certainly talked to people who've attended grudgingly rather than through choice, and you know, there's, I don't know, I think many of us would go, well, if I end up needing the sort of level of care in a residential aged care home, please don't offer me bingo, because I'm not a bingo person. So look, that can be done well, it can be done badly. I think transport has and the reliability of physical transport has certainly put a spanner in the works for in my locality for even, you know, visits with family members to restaurants and back again can be undermined if you can't rely on transport being available. So look, I think, you know, the tension between the for-profit residential aged care home funding model and the needs of individuals really means that you know, the first attention is on meeting accreditation criteria and minimum standards, and those nice to haves, well, that's how they're perceived, are left to later, and I think that's a real shame, because I think they're actually essential to have, not just nice to have.
Absolutely. Is there any of the other questions that you would like to focus on, Mark, and get some input?
One area where I think the policy development has been really lacking, mostly through want of asking the question, is what do community groups need in terms of infrastructure and support to thrive if the health sector starts sending people that are isolated or lonely or with poor mental health or need for physical activity but not currently engaged in physical activity? What do they need to continue to run is one focus on, and the other area is where would we get a workforce of link workers? So kind of what sort of person makes an effective or good link worker? Those two questions I don't think have been adequately addressed in a scalable way. They've been addressed in in our project we had the intake person from the neighbourhood house that was a link worker. Oh, great, but there's not enough of those people to go around with. So you know, do we just put an expression of interest out to lay people and say, here's your training course and here's some money, or do we try and build an existing workforce and add link worker skills onto it? I'm unclear of the best way forward, but I'd love the collected wisdom.
There was a comment around sort of peer navigators or peer-to-peer support earlier on. And I think Kristen has also talked about social workers and discharge planners. Maybe not in the exact same context, but yeah.
So the peer-to-peer workforce is something explored in a piece of policy development around the management of severe mental illness and physical health simultaneously. This was a piece of work that was focused on the 20-year life expectancy gap for people with severe mental illness, mostly from entirely preventable medical conditions that outside of the context of severe mental health are managed perfectly well in the health system. What came out of our community expert groups and lived experience groups in that research was a great desire for peer-to-peer workforce, for people who have lived experience to be able to share that experience so other people can benefit from the journey they've taken. And I guess the bigger question is, why doesn't that happen? And it doesn't happen for much the same reason that social prescribing doesn't really happen. Funding levers pay for face-to-face care with individuals like me in a consulting room, and privacy rules and other things make me feel unable to connect two people together who are both patients, because anything about a patient is absolutely confidential. I think that's where specific social media products have a potential way of being harnessed to connect people together, and in spaces that are not bound by confidentiality in the same way, where people can explore the level of confidentiality in sharing themselves. So look, I think that's an aspect of social prescribing to encourage and enable peer-to-peer support.
Brilliant. Is there any other comments around?
I might just pick up while we're thinking about other comments around discharge planners and nurse navigator roles. The acute hospital sector obviously tries to manage and coordinate discharge and services, but my experience of those and some of the outcomes of the coordinated care trials from years ago that were run in different states is that they didn't ever reach the potential that they could have done, mostly because the driver for them was acute hospital services, and therefore they were set up to deliver the needs for acute hospital services, which were also the needs for patients, for the recipients of care, but they weren't as well integrated with primary care, with prevention, with ongoing community care as they could have been. So it's more the implementation than that was wrong, rather than the concept that was wrong. I think discharge planners and nurse navigators do a fantastic job at that kind of pointy end of the pyramid where people's needs are very high and complex, but at the prevention and kind of middle section of the population where the needs are lower, it's not a model that's big enough to address those needs, has to be much more mainstream. But yes, I would hope that primary care nursing and the multidisciplinary teams within general practice can grow, and that we can have increased roles for people from different disciplines working with and in general practice, much more so than currently happens, and roles will then emerge to do that complex care navigation, as well as potentially navigating the social prescribing space.
Amazing.
If there are any concluding remarks from anybody, I hope we can capture and save some of the chat here. It's been really informative and helpful. My concluding remarks is, look, I hope I've been able to share with you some of the vision for social prescribing and some of the ways it can help at an individual level. Also some of the challenges at scaling it up at a national level. But I think we have to do it. We can't expect the model that we developed in the 1950s and 60s of managing acute care needs in one-on-one consults to be fit for purpose today. And so I don't think there's any choice. It's a case of, do we do it now, or do we bumble around for the next 5 to 10 years? And I think that if people on the call today have opportunities to engage with small projects, they can then coalesce to a groundswell of support for social prescribing, and others that have the ear of governments and people and funders can use that influence to remember that social prescribing is an affordable, patient-centred and important thing for Australia to develop. And pharmacists, yeah, absolutely.
Yeah, brilliant.
Pharmacists are there, they're through that, the community, and they could certainly have a much greater role in connecting people to more than just the dispensing of medicines and direct healthcare advice for problems.
Definitely. And yeah, I love this last comment around it being health and social care, not just health, as they are inseparable.
Absolutely.
Anything final from you, Mark?
No, just thank you very much for the opportunity to talk like this, and thank you for keeping me to some sort of time level, because otherwise I can get too enthused and keep going. So it's been great, and I've been overwhelmed by the deep thought that's gone into the commentary that I've been reading.
Absolutely. Yeah, I think I could keep firing off questions for another couple of hours. Well, please, everyone, thank Mark for being here. Just write a nice note in the comments if you can. Also letting you know that the recording of this presentation will be distributed as a YouTube link when it's ready. And one final thing is that we have our Australian Frailty Network 2026 Summit coming up, obviously next year, and the details of that are on our website if you would like to have a look and experience more of these kinds of conversations. So thank you once again, Mark. Really appreciate you being here, and yeah, we'll look forward to seeing how the future of social prescribing evolves.
Thank you.
No worries. Thanks so much.